Okay, so the question that occurred before we start is, when we're looking back at somatic versus autonomic, why with autonomic do you even have a ganglion in the middle? Right? It's really the same answer as, why do we have synapses at all? Wouldn't it just make more sense to have the nerve go directly to the muscle and electrically stimulate the muscle? Why have a synapse? Any ideas?
I think you said it can either be excitatory or inhibitory, so inside the synapse, or just go directly out of that ganglion and the synapse at that target.
Right, so the answer that was said is correct, meaning if you look at the autonomic, you have excitatory and inhibitory activities. That means that you have the same pathway, but you can use the same pathway to make a right turn or a left turn. So you have options. You can actually do different things with that same exact architecture. So if you have a synapse, you can release a different type of neurotransmitter at that synapse and get a different response. Okay? This is sort of the biologic diversity that we have. All right, in our second, go ahead.
Are you talking about like if you want to raise your heart rate or lower your heart rate, for example?
No, I'm talking about the different target organs. Okay? Hold off until we get into comparing and contrasting the different types of architectures. So the first architecture I want you to be practicing is what we just went over. Somatic versus autonomic. Now, answer this question. The parasympathetic division does what? Who's got an answer and tell us why? Parasympathetic division does what? I'm just going to have to call on somebody. Who's got an answer? B. Why? Why is it B? Why is it not D? Does it increase metabolism? No. Is it associated with fight or flight? C? No. Does it decrease blood flow to the skin? No. It mediates digestion, urination, and reproductive systems, like we went on. B's the right answer. All right, so now what I want you to do is this. I want you to draw this picture, which some of you are alluding to, and I think it's because you read ahead, which is perfect. So now you're ready. I want you to draw picture A and picture B on your notes. And this is basically going to be your homework, too. And this is what we're going to be doing in SI. I want you to draw picture A, a presynaptic neuron with a long axon that synapses onto a postsynaptic neuron with a short axon. And then in picture B, I want you to draw the opposite. Now, your drawings can be very, very simple. Okay? Some of you are like, I am the world's worst drawer. Okay, so let me just show you some examples of my drawings so that you guys can just laugh. Ready? Okay. Oh, look, there's a little bug cruising. Oh. Going after my neuron, dude. All right, go get your own neuron. So there's a long one up top, and there's a short one down low. My kids think the one on top looks like a snail with a long neck. So you know that's a neuron, honey. Dad draws a neuron. I'm like, oh, okay. What's a neuron again? Okay, so maybe something like that is I want you guys to be able to do. Okay? And now I want you to think about answering this question. A or B is an example of a sympathetic pathway. If somebody asked this question, sort of, okay? Is pathway A or B sympathetic? Which one was B again? Which one was A? A was long short and B is short long. So which one is sympathetic? Anybody know this? B. B is the right answer. The sympathetic pathway has a relatively short preganglionic fiber and a long postganglionic fiber. That's the sympathetic pathway. The parasympathetic pathway has the opposite, relatively long preganglionic fiber and a shorter postganglionic fiber. Now, someone's going to ask why. Like, I actually don't know. I don't have a good answer as to why it's that way. But what we see in the nervous system is we have these phenotypic architectures that characterize sympathetic fibers one way and parasympathetic fibers another. There's got to be an explanation, but I haven't discovered it yet. So what this actually does for us is it gives us different architectural strategies by which we can design and release different compounds to cause different actions. Okay, so now we're going to start comparing and contrasting different types of fibers. So we look at the first fiber that we're going to describe, which is cholinergic. Cholinergic fibers secrete acetylcholine. That's why they're called cholinergic. Cholinergic fibers secrete acetylcholine. Acetylcholine esterase works very fast. That's an enzyme that breaks down acetylcholine. So once the acetylcholine is released into the cleft, it has its activity, and then it actually is degraded or absorbed or diffuses out. But if acetylcholine esterase, this enzyme, is released, it actually has its activity very, very quick. We see this neurotransmitter in both the sympathetic and the parasympathetic side of the nervous system. It is more preferentially used in the PNS, but you will find it in both. If we look at the receptors that are going to respond, now we're moving to the receptor side. We have the fiber that releases the acetylcholine, then we have receptors on the target tissue that respond to it. This is where we're going to get some differences in effect. We have two main types of cholinergic receptors. They're called cholinergic receptors because, why? They bind acetylcholine, so we call them cholinergic. The first family of cholinergic fiber is called the receptor, is called the nicotinic receptor. The nicotinic receptor is a type of cholinergic receptor. Well, why is it called nicotinic receptor? Why isn't it called cholinergic receptor 1? It's also stimulated by nicotine. And when it was being researched, that's what the discovery was, is that nicotine activates this receptor, so they called it the nicotinic receptor. I think it would be nice if we just changed the textbooks to say cholinergic type 1. Okay? But that's not what they say. Okay, so you need to know that a nicotinic receptor is the first type of cholinergic receptor. Now, these guys are excited, or activated is another word for it, by acetylcholine. They're found in the autonomic nervous system in the ganglion. They're found in the adrenal medulla, and they're also found in skeletal muscle. And if you look at this picture over here, you can see here's the receptor, there's nicotine binding. When acetylcholine binds to the nicotinic receptor, but nicotine would do the same thing, it opens this gate and sodium floods in to the inside of the cell. If sodium rushes into the inside of the cell, what do you know about that event is important? What is it doing? It's causing depolarization. If it reaches threshold, then it would cause what? Action potential. Aha. Okay? We're starting to connect the dots from the nervous system to muscles and glands. Does this make sense? If we look at our second type of receptor, this one's called a muscarinic receptor. Again, I would like to rename it in the field as cholinergic receptor type 2. Who's with me? Just like 4 of you. Sweet. Okay. So you 4 can get that freebie on the exam. But the rest of the 396 in here have to know No, we all need to know. I'm just kidding. Muscarinic is the name of the receptor. Why is it called the muscarinic receptor? Okay. Some theories. So maybe how it's activated. What was the sense thing? I didn't quite connect that. Oh, different senses of smell? No, not really, but it does have to do with how it's activated. So there's a mushroom toxin known as muscarine, and that toxin actually binds and poisons this receptor. And that was also discovered in the laboratory. So they call it the muscarinic receptor. Okay? That's the history. What it does is variable. Its activity, some cells are excited and some cells are inhibited. You're like, well, that's confusing. Yeah. But it's important that you have different types of activities. So, for example, it will excite intestines and cause contraction, but it inhibits cardiac muscle. So if you look over here, there's M1, 3, and 5, M2 and 4 over here. Muscarinic receptors 1, 3, and 5, there's a family of muscarinic receptors. So you can see very quickly that this is even more complex than what I'm presenting. But we're just going to cover the very, very basics in this course. So if you look at muscarinic receptors, which are a subtype of a cholinergic receptor, there's at least a family of 5 different variations of muscarinic receptors. These odd-numbered ones, M1, 3, and 5, through this G protein, actually release calcium and are stimulatory in their activity. And that calcium release and that stimulatory activity excites intestinal motility. Okay? Over here, 2 and 4 are actually inhibitory. Through this G protein cascade, it downregulates cyclic A&P, and as it's inhibitory, it's actually going to inhibit cardiac muscle. Okay? So you have now your first example of how you use the same pathway with the same receptors, same pathway with different receptors using the exact same neurotransmitter. You get different responses. Well, you can change the neurotransmitter as well and bind it to different receptors and get also different responses. So we're going to see that next. Question?
Do these work simultaneously together? So if I'm going to stimulate one aspect, am I always going to inhibit the other?
No, not necessarily, because you could actually just release it in that certain area. Okay? But the question is, are they going to always work in concert? You'll have side effects, right? We're going to look at an example of a drug that has a side effect associated with it, and it'll become a little bit more clear. Because a lot of these compounds can be released into the bloodstream. If they circulate around, they actually can bind in distal locations. But at the level of acetylcholine as a neurotransmitter, it's only locally being released. Okay? It's not planning to circulate around. In fact, as it's locally released and stopped being needed, esterase, acetylcholine esterase, digests it and makes it go away, so that it doesn't get gobbled up by some other cell and have some side effect. But pharmacologically, when we take drugs, we usually get side effects because they go systemically. Question?
The second bullet point for both receptors, are those the targets for these receptors?
Like here? Yes.
Okay.
These are the targets. So like the target for the nicotinic, skeletal muscle, autonomic nervous system ganglia, adrenal medulla. Target muscle for muscarinic receptors, lots of glands like sweat glands, smooth muscle, and cardiac muscle. If we look at our question, parasympathetic division is stimulated. What neurotransmitter is released at the effector organ? What's the answer? Acetylcholine. That's what we've been talking about. Okay? Let's look at a second type of receptor now. So we talked about our cholinergic receptor, and the 2 subtypes that you need to know are what? Nicotinic and muscarinic. Now we're moving to our second family of receptors known as adrenergic receptors. Okay, adrenergic receptor. There's also two types here that I want you to know. These receptors are going to respond to norepinephrine. Okay, they can also respond to epinephrine, but more commonly it's norepinephrine that's being used as the neurotransmitter. Norepinephrine, we said, was noradrenaline, right? Noradrenaline is being released, and a adrenergic receptor is responding to it. Adrenergic, noradrenaline. So noradrenaline, adrenergic, acetylcholine, and cholinergic. So that's how these names get connected. Does that make sense? So with our adrenergic type of receptor, we're going to see alphas and we're going to see betas. Those are our two types. Alphas and betas. And I'll get to this picture in just a minute. But let's talk about the alpha adrenergic receptor. These guys usually are excited by norepinephrine. And there's two subfamilies. And you can see over here, alpha 1 and alpha 2. So alpha 1, this one is blue. This one is going to cause vasoconstriction of smooth muscle down here through this channel, through this phospholipase activation, releasing calcium and causing smooth muscle to contract. Alpha 2 target is this pathway. This one is actually going to stimulate smooth muscle contraction in a slightly different way. Okay? Now, if we look at our third type, which is our beta subtype of adrenergic receptors, we're going to see beta 1s and beta 2s. And the beta 1, so usually norepinephrine inhibits in the beta adrenergic type. The beta 1s have an exception. The beta 1s actually stimulate contraction of the heart instead of inhibit. But the beta 2s are actually relaxing airways and causing bronchial dilation because of relaxation of the smooth muscle. So let's look at this and then I'll get to your question. Over here, here's our beta family, and you can see down here we've got a little caveat. The beta family of receptors, the beta 1s, cause the heart rate to go up or cause contraction if they're stimulated. And beta 2, if they're stimulated, this has an inhibitory effect, right, causing relaxation of smooth muscle. Well, the airways are lined with smooth muscle in the bronchi, in the trachea, and so by relaxing that smooth muscle, you cause bronchodilation. Okay? Bless you. Question?
I was just going to ask you for alpha 1 is also vasoconstriction.
Vasoconstriction, sorry. Vasco. Vaso. So there's an extra C right here. Take the C out. V-A-S-O. Oh, there's no S here. So, yeah, this is totally misspelled. Good question. You know what? Let's fix that right now because, you know, I'll forget. Watch. You like that better? I do. Thank you. Okay. Oh man, all right. We got sidetracked. Okay, so let me show you an example of how this plays out. This is a pharmacology example. Okay? Does everybody know what this little dude is? It's an inhaler. Okay? How many of you have an inhaler? Or have used one, or has a friend that has one? Okay? How many of you have used your friend's inhaler to see what it feels like? I mean, come on, let's be honest. There's only cameras watching you both. Alright. So if we take this little insert that was folded up like 70,000 times and put in the package, okay, and we unfold it, and you actually read it, and you zoom in with a high-powered device so that you can actually read it. Is that legible? If you stop moving, Keller, then it is. Holy smokes. It's like too much. Okay, hang on. Autofocus. Boom, boom, bam. I know. Close your eyes for a second. There it is. Is that pretty good?
Yeah.
Yeah. How come it's what's wrong with my lamp? Oh, maybe my lamp is Is that better?
Oh yeah.
Oh yeah, that's way better. Okay, lamp. Okay. I know, I hit the autofocus button. So let's read this. Prime action of beta-adrenergic drugs stimulate adenyl cyclase, blah, 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 blah. Okay, let's go down to the second paragraph. In vitro studies and in vivo pharmacology studies, that means benchtop studies in vitro and in life studies, probably in animals and humans, of the pharmacology have demonstrated that albuterol, which is this inhaler, has a preferential effect on beta-adrenergic receptors compared with another drug. Okay, so we know we're talking about beta-adrenergic receptors. While it's recognized that beta-2s, you see the little subscript 2? Beta-2 receptors are predominant receptors in bronchial smooth muscle. Data indicate that 10% to 50% of the beta receptors in the heart may also be beta-2 receptors. Okay, 10 to 50%. So, you can read on if you want, but that's the point I'm trying to make. So if you use this inhaler, or if you use a stronger format of it, which is like a nebulizer treatment, how many of you know what that is? It's like a little device that plugs in the wall. It's basically like a pump with like a little, like bong apparatus thing. You put medicine in, and then, you sit there like you're in a smoking den. And ironically, you're taking these drags so you can breathe better, okay? So, I mean, those of you that have seen this, you know what I'm talking about, right? But it's an aerosol of the drug, and that's albuterol a lot of times that they put into the nebulizer treatment. So what's the side effect after taking albuterol? Shaky. And what happens to your heart rate? It goes way up. Okay? So the beta-2 in the smooth muscle of the lungs is dilating, but the beta-2s that are nonspecific but are getting drug in the heart actually are also being stimulated. So if I go back to this, the pharmacology tells me that these beta-2s, it works to relax the airways. An asthmatic having an attack takes albuterol, the airways dilate rather quickly. Okay? But if the drug is delivered most commonly in nebulizer format, there's enough of the drug there that one of the side effects is their heart rate is elevated, because it actually stimulates beta-2s in another location of the body. So this is our side effect pharmacology. Now, if you had a patient that had heart compromise, like was in congestive heart failure, do you want to give them lots of albuterol? No. So this is why this kind of stuff actually does matter. Is if you don't understand that, okay, I'm going to take a drug and I'm going to dilate the airways with beta-2 agonists. That's what these are called, beta-2 agonists. That's what I wrote on this little piece of paper, beta agonist. Let me show you, just to prove it to you. Prove it to you that I wrote it down, right? See? So these are beta agonists, specifically beta-2 agonists, and you're going to prescribe that because you're the physician, but your patient has heart problems. You better know that there are beta-2 receptors in the heart that could cause problems. So you may want to back the dose off. You may want to choose a different bronchodilator that doesn't stimulate beta-2s. Do you understand what I mean? So I'm trying to give you a real example that you can put your mind around to understand these differences. Okay, so now let's answer the question that was being posed a little bit earlier. Is, okay, how do I classify these guys? Well, in our sympathetic division, we're going to see our preganglionic fiber is always going to be cholinergic in style. And we see that our postganglionic fiber is typically adrenergic, and every now and then we'll see a cholinergic type. And now you know the difference between adrenergic and cholinergic. Adrenergic referring to norepinephrine, cholinergic referring to acetylcholine. On the parasympathetic side, much more straightforward. It's always cholinergic on the pre, and it's always cholinergic on the post. Okay, so given this information, let's ask this question. Norepinephrine binds to beta-adrenergic receptors on bronchioles. It's most likely binding to what? Beta 2s, B, nice. Pretty easy. Could you get a clinical setup question, like with an inhaler on the exam? Okay, good. All right, let's see how well you do on how to put this together. This is where, if you did the reading, this will be helpful. I want you to draw. You can use your short, long drawing that you started. You can use those. And I want you to draw a generalized parasympathetic pathway and label the following. I want you to secondarily draw a generalized sympathetic pathway and label the following. Now you're going to need more than just your short and long to start. Right? You're going to have to draw more than that, but you can start with those. And information that will be valuable to you is going to be this table. Being able to do this and familiar with it will help you on the exam. In fact, if it was me, the first thing I'd do when I got my exam packet is I'd draw these. If you study them, draw them, and then use them to answer the questions in the test. Okay? You guys done drawing? Go. Okay, after you draw them, put in the correct neurotransmitter. We're raising the bar now. Who's still working? Couple, okay. Well, that's you. All right, you ready? So your parasympathetic fiber, let's start with that because it's the simplest one. Should look something like this. So you should have a preganglionic fiber that's long, a postganglionic fiber or neuron and fiber interchangeable, that's short, and it's always acetylcholine at both locations. So the neurotransmitter is acetylcholine being released here, acetylcholine being released here. Okay? The receptor here is a nicotinic receptor, and this receptor here is a muscarinic receptor. Now our sympathetic fibers is where we have our option because it's usually one, but not always, right? So it's usually adrenergic on the post, and every now and then it's cholinergic. So if we look at this, we have two different options of sympathetic fiber architecture. We've got our sympathetic adrenergic fiber and our sympathetic cholinergic fiber. So here we've got short and short, we have long and long, but what we alter is we alter the secondary neurotransmitter at the target cell. So we alter norepinephrine up here, and we switch it to acetylcholine down low. So it's norepinephrine to an adrenergic receptor, and it's acetylcholine down here on the sympathetic side to a muscarinic receptor. And between these three different variations of architecture, we can get a number of different types of responses. And why do we want to do that? Well, sometimes we need to inhibit contraction. Other times we want to stimulate contraction. And instead of reinventing a whole new pathway with brand new neurotransmitters and receptors, we just use a different motif, and we use the same roadways, so to speak. Okay? So, during a fight or flight response, which type of receptor in the piloerector muscle responds to the neurotransmitter? What's the piloerector muscle? The muscle that goes where? Smooth muscle. And what? It's around hair. Like on your, it's what gives you goosebumps and makes your hair stand up. Okay? So the piloerector muscle directly innervates or inserts onto the hair follicle and causes it to stand up. So, alpha adrenergic, nicotinic, beta adrenergic, muscarinic, or you cannot determine. Think about it a little bit longer. It's not nicotinic. It's the alpha adrenergics. Alpha adrenergics. Okay, let's try this one. Remember what we introduced in the last lecture? Right? We've got these different pathways. We're specifically focusing on these three. And I want you to answer this question. You're running away with someone chasing you with a hatchet. Okay? Which is a correctly ordered pathway of neurotransmission that's taking place. Someone's chasing you. So, what's going to be a correct pathway here? This is a tough one. But you should be able to study this outside of class and be able to explain why each one of those lines is either right or wrong. So let's walk through it. Let's look at A. A says the splenic nerve to the collateral ganglion to skeletal muscle. But the splenic nerve does what? It innervates the abdominal cavity, right? You with me? So this one can't be right, A, because it doesn't go, the splenic nerve doesn't go to skeletal muscle. You follow that? Okay, let's look at B. Sympathetic nerve, paravertebral ganglion to the sympathetic nerve to skeletal muscle. Does the sympathetic nerve go to skeletal muscle? Where does it go? Heart, thoracic region, salivary glands, lungs. Okay, so this isn't correct. C, ventral root ganglion to the spinal nerve to the heart wall. Okay. Oh, and this one's actually saying ventral root ganglion. Now, you asked the question earlier, so I'm kind of going against myself. That's actually not a fair test question. I told you not to worry about the lateral. But the answer here does relate to lateral versus ventral. Okay, because it comes from the lateral, not the ventral. So this one's wrong, C, because it's not the ventral root ganglion. It's actually off the lateral aspect. But I won't ask that particular version in the exam because we said we'd focus on ventral and dorsal. Okay, but let's pretend, at least for lecture, that that's game on. Look at D. Paravertebral ganglion, spinal nerve to the blood vessel wall. Paravertebral ganglion, spinal nerve to the blood vessel wall. You guys like that one? I do too. That one's the right one. Okay. Let's look, just for sake of completeness, at E and see why E is wrong. Paravertebral ganglion to the splenic nerve to the hands and to the feet. Does the splenic nerve go to hands and feet? No. Okay, so that's why E isn't correct.
Keller,
Yes.
where's the paravertebral ganglion on the diagram?
The paravertebral ganglion are these right here. Okay, they're the collection of the cell bodies that are on either side of the vertebrae.
And what does it have to do with the lateral horn?
What does it have to do with the lateral horn? Well, the ganglion is the collection of where the signal comes to. So the signal comes out of the spinal cord, comes to the ganglion, and then it goes out from there. Okay? All right. I mentioned that we have the opportunity for dual innervation. And that's what we're talking about now. I want to give you some examples in the remaining time of dual innervation. Dual innervation means that you've got sympathetic and parasympathetic fibers going to that organ. It gives you a greater level of control. The example here that we have is in the pupil. So you can actually see that we've got antagonistic opportunities if you have dual innervation, or you have agonistic or cooperative. And the example that we'll use for antagonistic here is the pupil, meaning one does one effect and the other one does the other effect. So for example, if you look at the effect here from the brain, the pupil's dilated here, and on the right side the pupil is constricted. Well, the pupil dilation is controlled by sympathetic outflow, or an adrenergic effect, that can be traced back to the superior cervical ganglion. So in this ganglion, these guys are located outside of the spinal cord, but up in the neck region. And likewise, but in contrast, if you want to constrict instead of dilate, you would innervate it with a cholinergic effect from a parasympathetic fiber that is traced back to our ciliary ganglion that comes out at the level of the brainstem. So the parasympathetic fibers, oculomotor nerve 3 comes out, and this makes constriction take place. The sympathetic fibers that come out of the cervical neck region innervate down, and they actually cause a dilation effect on the pupil. So we've got both types of nerves innervating the eyes to allow different levels of light to come in. Now, let's look at agonistic. Agonistic is a cooperative effect. So in the case of saliva formation, we've got the parasympathetic nervous system creating the secretions, the watery secretions. The sympathetic nervous system is responsible for making a lot of the mucus, the thick substance, of which will encourage any enzymes in place to actually stay in location. The mucus is thick. The enzymes come out of the parasympathetic side, but they get stuck in location by the mucus that holds it in the oral cavity where digestion begins. Digestion is a word that means chemical breakdown. So chemical breakdown has to occur. So here you have a cooperation. You've got the parasympathetic response of slowing down to eat, releasing all of the enzymatic compounds that are digesting the food parts. Well, the sympathetic nervous system actually makes mucus in order to keep them in location and kind of hold them in place, make them sticky and attached to the food. So the question I want to ask, because the example I want to use is kind of an interesting one, but how many of you have heard of this meth mouth scenario? So let's see some really cool pictures, okay? So what happens with meth mouth? What happens with meth? Well, meth ramps up the sympathetic nervous system aggressively, okay? So these patients are really strung out on meth. They're going to be, bruxism is clenching of the teeth, right? Clenching and grinding the teeth, just because they're all kind of hyped up. That's putting a lot of stress on the teeth. Well, they usually don't stop to brush or floss, okay, because they're so addicted to the substance. So they generally have poor oral hygiene. They have under saliva production, or hyposalivation, right? Because they're not stimulating on the periphery, they're ramping up the sympathetic nervous system. So that makes a lot of mucus. But that mucus traps a lot of the enzymes, and the enzymes get stuck, and they start decaying the teeth. Okay, they start decaying the teeth aggressively. Okay, you with me? All right, let's look at this scenario. Do you always have to have dual innervation, like I'm posing with the eyes or like I'm posing with saliva and mucus production in the mouth? And the answer is no, you don't always need dual innervation. Because in this example with the blood vessel, we can accomplish vasoconstriction up top or vasodilation down low with just one type of nerve innervation. The nerve innervation we have here to the vessel, the artery, is a sympathetic nerve fiber. And what are these little hash marks indicating? These black lines coming across the nerve. Action potentials. Okay? So if you fire action potentials at this rate or that frequency, you're going to get vasoconstriction. You're causing the muscle to contract and the lumen diameter decreases. Now, instead of having a parasympathetic fiber innervate, like what we saw with the eye, here what you do is you just decrease the number of action potentials and you don't contract as much and it relaxes and dilates. So it's kind of like, you know, do you drive with your brake and your gas pedal in this fashion, where you come up to a stoplight and you just take your foot off the accelerator and the car starts to slow down? Okay? And then you induce the brake if you really need to stop. But you theoretically could come to a complete stop in a controlled fashion by not even using the brake, right? You could downshift, right? You could actually just take your foot off the accelerator and slow down. So that's this example. It's not as fast and as rapid. And so with the eye, we want to be able to focus and bring in light in very different conditions quickly. So this one doesn't happen as quickly, but you can do it with just sympathetic innervation. You don't need dual innervation. Okay? All right, let's ask this last question. You just had lunch, you're beginning the process of digestion. What type of receptor in your heart wall is responding to the released neurotransmitter? I'm asking about the heart. Muscarinic type D. Look at this and go over why each one is right or wrong. Okay? So let's connect these as we wrap up the remaining time to what we've talked about in the past. Stay with me, guys. We're just going to finish out. Remember, the peripheral nervous system is to bring information into the central nervous system. And then the central nervous system is going to outflow into the periphery and control events. So if things come into the cerebral cortex from the periphery, remember, things like the limbic system and the hypothalamus that are going to control things like emotion, memory, thirst, hunger. Right? The hypothalamus is this major control center of visceral motor systems. So the activity from the gut, the activity from the salivary glands, all of this is being controlled by the hypothalamus. If we look at the way things are linked up, right? We have our midbrain, or pons and medulla. We have cranial nerves that come out. Those are peripheral nerves now. We have oculomotor nerve 3 for constriction of the pupils. We have facial nerve 7, innervates the salivary glands, like what we just talked about. We have glossopharyngeal, also influencing salivation. And we have our vagus nerve number 10, innervating the thorax and the abdomen. If we go down low in the spinal cord, we start looking at defecation and micturition reflexes. So our periphery is sending signals back to the CNS where we just were. We just were in the last couple of lectures. All right. Following could occur together except what? Which ones couldn't occur together? Which one's out of place? C. C's out of place because all the other ones are dealing with sympathetic. Right? Okay. Go over these questions, guys. Here's your homework. You ready? I want you to draw those sympathetic and parasympathetic fibers, those 3 different versions. I want you to practice that drawing.